Welcome to the Touch Cases activity on applying patient and disease characteristics to guide the treatment of recurrent and metastatic nasopharyngeal carcinoma. I'm Dr. Nabil Saba, Director of the Multidisciplinary Head Neck Cancer Program at the Winship Cancer Institute of Emory University in Atlanta, Georgia, in the United States. I'm delighted to be joined by Dr. Victoria Villaflor, Director of the Head Neck Oncology at the Child Family Comprehensive Cancer Center, UCI Health in Orange, California, United States. Together, we're going to discuss 3 clinical cases of recurrent or metastatic nasopharyngeal carcinoma, exploring how different patient and disease characteristics can help inform the optimal treatment strategy for each patient. The first case is covering first-line treatment in selection for recurrent metastatic nasopharyngeal carcinoma. Robert is a 54-year-old male with no significant comorbidities. However, he has a history of smoking and alcohol use, namely smoking 3 packs per day and an intake of alcohol of 5 alcohol units a week. Investigations initially included a radiologic examination, a biopsy, a nasopharyngoscopy, and the diagnosis of nasopharyngeal primary carcinoma is made. He unfortunately had 14 lung metastatic lesions that were noted. He also had involvement of the retropharyngeal and supraclavicular nodes. His staging is deemed to be stage 4B with T1N3M1 disease. His EBV tumor status is negative, and his HPV tumor status is also negative. First, let's ask the audience, in the absence of a clinical trial, what is your first-line treatment option for this patient? Victoria, with the diagnosis of metastatic nasopharyngeal cancer, any comments you have on this case and its workup before we get to the management?
Well, I think that the workup was done very well. It's important to know exactly what you're dealing with as far as the load of metastatic illness going on, because if a patient were to have a solitary metastasis, the treatment plan would be very different. Additionally, the patient was tested for Epstein-Barr virus, which is key. You do want to follow EBV titers in patients who are, positive for EBV virus. This is a prognostic factor and is also helpful in allowing you to know what's going on during treatment. This particular patient had a keratinizing or WHO1 or 2 type of cancer. These are generally caused by tobacco and alcohol or by HPV virus. And his treatment is not going to vary that differently. There are a couple of exceptions from those types of patients that are EBV positive.
So what you're saying is that you would look, and we can come back to that, but you would look at the EBV status for these patients, but that initially when you have a recurrent metastatic, non-oligometastatic situation, there's not much difference that the EBV titer would make?
That is correct. There are a couple of the immune checkpoint inhibitors that are not indicated in patients with keratinizing or non-EBV driven nasopharynx cancer.
Yeah, and I tend to agree with you as well. I think my approach would probably be similar to what you're indicating. So let's ask the question then, what treatment would you suggest for this patient in the first-line setting? Let's suppose also, like we asked the audience, that a clinical trial wasn't an option.
Well, the preferred regimen would be cisplatin, gemcitabine, and toripalimab. This is a level 1 recommendation within the NCCN guidelines. So that would be my choice, and that's commonly what I do, provided the patient doesn't have any contraindications to cisplatin, meaning things like hearing loss or renal dysfunction.
this regimen was FDA approved back in 2023, late 2023, and it is listed as a preferred regimen in our NPC guidelines. We have to say, though, that there's a number of clinical trials using other PD-1 inhibitors in the same clinical setting that have read positive. However, this is our preferred agent or regimen. So we did talk about the EBV status not impacting the initial management of the disease. Is there anything else it would impact in your view when you look at the case in its totality, and especially, monitoring or future intervention?
Well, I like to use the EBV titer to monitor these patients. I think, it does, if the patient is actually shedding EBV virus, it does give us some indication of what is going on clinically with the patient. So I find it helpful to monitor that. Now, on the whole, does it really impact the way that we treat these patients? Not really. Most of the studies have been done in Asia for this disease. Their numbers are something like 25 cases per 100,000 patients, whereas the number of cases here in the US is somewhere between about 0.2 and maybe 0.6 patients per 100,000. So we have a far lower level of nasopharynx cancer. So most of our studies have actually been done in Asia, and we take that data and put it into the US for what we're going to ultimately use as standard of care. Additionally, the US is a little bit different in that only about 2/3 of our patients with nasopharynx cancer are EBV driven, whereas in China or Southeast Asia, it's going to be more like about 95% of the patients. So, the bottom line is that most of these studies were done in predominantly EBV positive patients. So the only thing that is really impacted by this in the future is going to be, number one, there's a couple of checkpoint inhibitors that are approved for EBV positive or non-keratinizing, or WHO3, however you want to put it, nasopharynx cancer, and that would be things such as pembrolizumab or nivolumab. The other drugs pretty much have an indication for EBV positive or negative, even though the numbers of EBV negative patients within the studies were low. So from a perspective of first-line treatment, it is not going to alter my treatment plan as long as there's not a clinical trial. Now, clinical trials often will ask specifically for EBV positive or EBV negative disease because they are different diseases.
Yes, and I do agree with you. In fact, we're using the EBV data because this is the most robust data we have at nasopharynx cancer, and we're currently applying it for all nasopharynx cancers. However, I do also agree that they're biologically different diseases, and the more we can understand through future clinical trials, the better. None of the guideline-recommended first-line treatment options require PD-L1 expression for management of patients. However, there is some suggestion that PD-L1 expression may be needed for future treatment plans and subsequent lines of therapy. Let's ask the audience, when do you test for PD-L1 expression in your patients with metastatic nasopharynx cancer? And so again, Victoria, this is a question that has also being of interest in this disease, and that when you look at non-nasopharynx mucosal head and neck tumors, PD-L1 seems to play a major role. But in nasopharynx, it seems to be a little bit of a different story. What is your take on it? When do you test for PD-L1, and do you really absolutely have to test for it?
I do test for it because I collect the data in that it may be something that is applicable to prognostication. However, that being said, in order to use a checkpoint inhibitor for frontline therapy, there is no reason to actually test for PD-L1. First of all, when you look at things like the Polaris trial or Jupiter 2, there really was no difference as to whether the patients were PD-L1 positive or negative. They still had responses to the checkpoint inhibition. That being said, I do not, necessarily think across any tumor type that PD-L1 testing has been like the greatest biomarker that we have in oncology, given the fact that you can get sampling error, you can get, it's transient, it can come and go. There's multiple different tests. It's not one of our better molecular markers, period.
Yes, and I take the limitations. We all feel it in the head neck field, even in non-nasopharynx cancer, we clearly need better markers. But I also agree that this is not something that adds the similar robustness as it has in the recurrent metastatic nasopharyngeal tumor. So the treatment suggestion for this patient, as discussed, is cisplatin, gemcitabine, and toripalimab. Robert, however, has some concerns about the immunotherapy changing his immune system, or in his words, messing around with his immune system. And he's anxious about the side effects of immunotherapy. Victoria, how would your discussion with a patient be when they ask about these concerns, like Robert, for example?
Well, I typically talk to them about what the side effects are, the most common, of course, being rash, fatigue. Then of course there's the issues with thyroid. You can become hypo or hyperthyroid. Those are the big ones. And then of course there's a very real, concern about things like colitis, pneumonitis, and pretty much any organ system can become inflamed, but those become much more rare. So we discuss the numbers, we discuss what the potential, side effects are, but then we also talk about, well, what does this mean as far as quality and quantity of life, which are the 2 points that I want to drive home with patients, because that is the whole basis of their treatment in the metastatic or recurrent setting, or non-curative intent. And essentially, the use of a checkpoint inhibitor in the Jupiter 2 trial actually brought progression-free survival from 8 months without to about 20 to 21 months with the addition of a checkpoint inhibitor. So that's more than doubling. Not only that, it improved, overall survival with the toripalimab in the Jupiter 2 trial by about 15%, going from about not quite 50% to about 65% at 3 years. So I think the benefit the benefit actually outweighs the risk in these situations.
So our second case is covering treatment for locally recurrent unresectable disease. And Jason is a 63-year-old male with grade 3 hearing loss and hypertension as comorbidities, in addition to a history of drinking 3 units of alcohol a week. He's a non-smoker. He's diagnosed with EBV-associated nasopharynx cancer 3 years ago. He received carboplatin and radiation, followed by carboplatin 5-FU. And upon follow-up, 2 years later, he started experiencing headaches, and imaging suggested recurrence of his tumor with further investigations that were initiated. And unfortunately, he was diagnosed with locally recurrent, unresectable nasopharynx cancer. His clinical staging was stage 3, T4, and 2 disease. His EBV tumor status was positive, and his HPV status was negative. So it would be interesting to discuss the different management options of this patient. Let's first ask the audience, which treatments would you choose for this patient whose disease has recurred locally and is unresectable? So with grade 3 hearing loss, indicating that this patient is ineligible for treatment with cisplatin, the preferred regimen based on NCCN guidelines is cisplatin-based. However, in this particular case, I'm interested in hearing your points, Victoria, in terms of how would you approach this patient?
Well, this patient is now in the recurrent metastatic type setting, and I would definitely want to give him a gemcitabine containing platinum doublet along with an immune checkpoint inhibitor. Now, there are a number of different options available. The one that, would be probably have the most data would be with carboplatin, gemcitabine, and penpulimab. That being said, it has been FDA approved, but a lot of sites don't carry it. So often we will substitute in carboplatin for cisplatin, and a lot of times I will end up doing carboplatin, gemcitabine plus toripalimab just because of the availability. And there really is not a huge difference in this scenario between cisplatin and carboplatin. When you're dealing with side effects that you need to avoid, such as worsening hearing loss or worsening renal function, I find substitution of carboplatin for many of these cisplatin-containing regimens has never been a big issue for us.
And I do agree with that. In recurrent metastatic disease and other diseases, certainly substitution in that setting specifically does not seem to make a huge difference. And I always wonder whether it's worth subjecting patients to the cisplatin toxicity, but that's another discussion as well. And I do agree with the carbo gemcitabine toripalimab regimen in this case. Those cases though are a little bit more complex in the sense that this is locally recurrent, no distant metastatic disease. At our center, we certainly whispered this patient for discussion in our tumor conference. Tell me a little bit, what factors do you look at? Would you consider any form of local therapy, for example? Um, and what factors should influence your decision?
Well, I do consider them for local therapy. We, have a very robust tumor board where I'm at, and this case would definitely be discussed. We, would turn to our skull base ENT surgeons to see what their take is on this. Additionally, we would also turn to our radiation oncologist. Now, given, reirradiation is going to be a huge deal in these patients from a side effect potential, I would want to make sure that they actually respond to induction therapy before embarking upon a reirradiation type of regimen. Again, after induction or after chemoimmunotherapy, I would actually have them assessed for either resectability and or chemo reirradiation.
Yes, and I think this is an excellent point, and I just remind the audience that this patient is immunotherapy naive. In other words, this is the first time we're treating this patient with an immunotherapy-based regimen. And, the immunotherapy may be a deal breaker. So I do completely agree with being a little bit proactive with starting this regimen early, and then reevaluate because, bottom line, there are patients who I think could be potentially having a long-term disease remission with immunotherapy. So we label this case as incurable. I understand the reason, but I think also we have to factor in the fact that we are initiating the immunotherapy for this patient. In this case also, I think raises a question. We do have few now FDA-approved immunotherapeutic agents. Penpulimab was also just approved a few months ago in the management in combination with platinum and gemcitabine for recurrent metastatic non-keratinizing EBV positive disease. Any preference here in terms of your choice of the PD-1 inhibitor, given that this is non-keratinizing?
My biggest issue is going to be whether or not I'd be able to get the penpulimab, because a lot of times it's not on formulary, or you may not be able to get it within the institution. Those are decisions that are made, by the institution as a whole. So, I think that's going to be the biggest issue. How about for you?
Yeah, I mean, I think I do have the same issues, which is that it's a very recently approved indication, and toripalimab is approved for regardless of the EBV or the keratinizing situation. And so I think there would be no reason not to use toripalimab. However, I think time will tell. We need to. I have never used penpulimab, but certainly if it is available, this is something to be on the list as well. I think we're going to need to gain some experience with it. Given that, let's go back to our case and see what happened to Jason. So he did indeed have a first-line treatment with gemcitabine. He initially had a first-line treatment with gemcitabine and carbo, plus an immune checkpoint inhibitor. Unfortunately, he progressed on this after this line of therapy for recurrent disease. And so a second-line treatment now needs to be considered. But before we discuss this, let's look at which second-line treatment would be selected for this patient by polling the audience. And so again, Victoria, what factors, I should say, would you consider when selecting a second-line treatment?
Unfortunately, when they actually progress through, a platinum-containing doublet with an immune checkpoint inhibitor, it's concerning. These patients generally do not have great outcomes. I would definitely try to get this patient on a clinical trial of some sort. If that were unavailable, or he were not eligible for the clinical trials, couldn't travel for one, my next choice would be a taxane, because that's considerably different than all of the other therapy that he has had to date, and may have some efficacy. There's also, there are some studies currently that are ongoing, looking at, cabozantinib with nivolumab and ipilimumab in the United States for, patients that have failed prior immune therapy in the second and third line setting. I think that those are all good options, but in the absence of a clinical trial, and the fact that if the patient is unable to travel where there is a clinical trial, then a taxane would be my choice.
Yes. And this trial is open through the Alliance group. And I agree that we need more innovation for these patients. Certainly, there's a good track record of cabozantinib in combination with PD-1 inhibitors in head and neck cancer, but also a good track record of VEGF inhibitors in combination with PD-1s in nasopharyngeal cancer. It's important to remind the audience that toripalimab is also approved in that setting. Okay, in our third case, we're going to discuss treatment selection in a patient who has comorbidities, namely autoimmune disease. And here we have Sandra, who is 49 years of age, and she has a known diagnosis of systemic lupus erythematosus. The disease is, however, currently inactive. She's not requiring treatment and has not done so for the last 2 years. She has type 2 diabetes managed with oral anti-glycemic agents. She does have a history of smoking and smoked 1 pack of cigarette a day, and did have some history of drinking alcohol. She comes to us with a diagnosis of metastatic EBV associated nasopharynx cancer. Her clinical staging at diagnosis is stage 4B, T3N3 M1 disease. Her prior treatment was gemcitabine and cisplatin as a first-line treatment, and her current status shows that her disease has progressed. Her PD-L1 test is positive at 5%, and she does have an HPV positive disease based on her histology. Let's ask the audience, what would be your second-line treatment of choice, and what would you recommend for this patient? This is a situation where the patient has already received treatment with recurrent metastatic disease, however, with regimens that did not include immunotherapy. And so what would be your take on this, and what would you recommend for this patient?
This particular patient appears to have lupus, and it seems to be relatively quiescent or stable. She's not requiring a lot of immunosuppressive therapy. And there are data, for using immune checkpoint inhibitors in this patient population. The way that I would address this is I would seriously consider an immune checkpoint inhibitor in her, because it has been shown to, be beneficial in patients with nasopharynx cancer. So the best way of actually dealing with this patient would be to, number one, get her autoimmune disease team involved, because, they are going to need to be there and helpful in monitoring and manipulating her medications from a lupus perspective, and you want everybody on the same team. I would proceed in giving her an immune checkpoint inhibitor such as toripalimab. And essentially, I would monitor her very closely. But I think the benefits of an immune checkpoint inhibitor in a fairly stable patient with autoimmune disease, not requiring a lot of immunosuppressive therapy, would far outweigh the risks.
Yeah, I do agree with that. For the audience sake, so she did not have any treatment for her lupus over the last 2 years. Do you think you would be more leaning towards starting something while she's on immunotherapy, suppressive doses, for example, of low dose steroids, or would you basically, and I'm asking this question not because there is a clear, guideline, and we're discussing here situations that we face in clinic, but they're not really very well, delineated as far as guideline. Or would you basically start the immunotherapy and monitor and see what side effects the patient has?
I would do two things. Again, in working in conjunction with her autoimmune disease team, I would strongly encourage to start the immune checkpoint inhibitor without adding immunosuppressive therapy. Most of the time, when these patients with underlying autoimmune diseases have immune side effects, it's generally other immune side effects, not necessarily their underlying autoimmune disease. So I think if she's not been on any type of immunosuppressive medications for her autoimmune disease, I would not be inclined to have them start, but I would be inclined to make sure that her autoimmune disease team is following her closely.
Yeah, yeah. I think it certainly pays off to have other experts also help us in these situations. we discussed this before in the previous cases as far as second-line therapy. But do I take that you would use toripalimab in this case?
I would. There's also data with penpulimab, nivolumab, tislelizumab. There's also, in TMB high patients, you can use pembrolizumab. There's a number of immune checkpoint inhibitors, but, at our institution, we would be going with toripalimab in this patient second line. It is the preferred treatment. After progression for patients who have not, had an immune checkpoint inhibitor in the past. So that would be what I would go with.
I would agree with that too. The discussion of substituting PD-L1 inhibitors for one another is really an interesting one. But it's always good to remind the audience that these are not necessarily equal when it comes to clear mechanism of action or detailed mechanism of action. They're two different agents. And so we have to really go with what the clinical data is telling us. And here in the second line setting, do you think the PD-L1 test will carry a higher weight than in the first line setting? Or, I personally don't necessarily, rely too much on the PD-L1, whether it's first or second line, but there is some data to suggest that this is more relevant in the second line. Do you agree with that, or do you?
I think there's some data to suggest that there may be some relevance, but again, I don't use it as a marker for whether or not I'm going to give an immune checkpoint inhibitor, whether it be first line or second line.
Great. So this case is very interesting because it poses a dilemma to many medical oncologists in the fact that the patient has lupus, or at least a history of treated lupus. A diagnosis of an autoimmune disease has the potential of impacting the management and clinical course for these patients. So we want to be very careful when we embark on starting immunotherapy, at least in very close monitoring, and also in seeking advice and consultation from our colleagues for the autoimmune disease. So let's poll the audience. How would lupus or any other comorbid autoimmune disease impact your decision to use immune checkpoint inhibitors for these patients? So, I think this patient is of interest. She has not had active disease. And so we would maybe be more encouraged to try something. What about patients who are on chronic immune suppression? Patients, for example, with organ transplantation, renal transplantation. What's your take on that?
Well, there has been quite a bit of work done by Glenn Hanna on this, and he, works very closely with his renal transplant team. And they often will alter the patient's medication and try to drive down the immunosuppressants as much as possible. But again, here in the situation of renal transplant patients, it's also feasible to give the patients immune checkpoint inhibitors.
Yes, and certainly what I would say is the data that has been generated by Glenn and other in that instance is really encouraging. I would say I would still want to have a consulting team when obviously we treat these patients because of the intricacies of their immune suppression.